Welcome back. This is Module 3 of the C3IFT course, and this covers pharmacology that's specific for the C3 medic. So medications are going to be discussed based on the categories according to the West Virginia approved medication list. And please note that the content will only reflect information regarding the C3 or the class 3 medications. It's not going to look at class 0, 1, 2, 4, 1, 2, or 4, etc. So content will also focus on the ability of the C3 to either be primary administration, re-administer, titrate, or monitoring the drip. And any medication or requirement that's outside the C3 scope should immediately be referred to as a CCT call and call in for additional assistance and support. So this is a list of the medications that we're going to be looking at today. When it comes to the sedatives, the medications are intended to alleviate or minimize the physical and physiological effects of stress and anxiety that is related to injury or illness within the transport environment. And the three medications that we're going to talk about today include Versed, Ativan, and Valium. So with the Versed, this is considered a 3A, B, and a 2C. So we should be able to not only be primary administer, but also re-administer and titrate, as well as monitoring the patient who has received Versed. This is a short-acting benzodiazepine that does have both hypnotic, sedative, and amnesic properties, and it's really good for patients who require sedation for general anxiety, or maybe they have an acute seizure activity. Some of the contraindications you need to be worried about is the chance for any patient who has hypotension or narrow angle glaucoma showing signs of shock or alcohol intoxication should not receive Versed. Some of the side effects can include respiratory depression, CNS depression. They can become hypotensive, thus the reason why the hypotension is a contraindication. It can change their cardiac system by causing them to move into bradycardia, and your dose is somewhere between 1 to 5 milligrams as a slow IV push, and we're going to look at it specifically within the protocols itself. But the biggest thing we want to remember with Versed is to make sure that we reassess respiratory rate and quality. We want to make sure that we check for any change in their level of consciousness and also the blood pressure. And remember that with our benzodiazepines, Flumazenil is our reversal agent. Ativan is the other medication. It's also the same way. It's a 3A, B, and C. And it's a short-acting benzo. You'll see that it's pretty much essentially the same. The biggest thing is the dosing. The dosing is 0.5 to 2 milligrams. Again, that's a slow IV push. And then finally Valium. And Valium is in a different color here only because Valium has been, this particular slide has been added to the original Module 3 PowerPoint presentation. So this is one that's been added on because this is a drug that's been added into the list that wasn't originally there when they created the presentation to start with. So that's why it looks a little different. But Valium is considered a 5A, 5B, and a 2C. So that means that even the intermediate can actually primarily administer, re-administer, and then of course monitoring as well. So this is something that's well within your scope of practice and your ability. It is a short-acting diazepine, benzodiazepine with sedative. It has skeletal muscle relaxant properties, which is a little different from the other two medications we've looked at. But again, your dosing is going to be the primary difference here. The dose for Valium is 5 to 10 milligrams as an IV or an IM push. Now, analgesics that we're going to look at, the medications intended to alleviate or minimize the physical and physiological effects of pain that's related to injury and illness within the transport environment. So the three medications that we're looking at today include morphine, Demerol, and fentanyl. Morphine is considered a 4A, 4B, and a 3C, so you will be able to do all things associated with it, primarily administer, re-administer and titrate, as well as monitoring. And remember, this is the only medication that's approved as a monitor-only infusion. So this is the only one that can be set up as an infusion and monitored by the C3IFT paramedic. So a field paramedic can initiate and give morphine, and they can re-administer, but it cannot be done as an infusion. Only the C3 can do the infusions. So this is an opiate narcotic analgesic. It's again used to deal with moderate to severe pain in patients that are suffering from cardiac-related emergencies. Some of the contraindications, though, we do want to be very much aware of hypotension, shock, and CNS depression in patients that are on our trucks. And we also want to make sure that if this is a patient who has a head injury and the chance for increased intracranial pressure, that's probably not the patient to receive the morphine sulfate. Your dosing is commonly 5 to 20 milligrams per hour or more. And remember, we're looking at this from an infusion standpoint, which is a little different. But you want to make sure that you constantly monitor that patient and ensure that you've got, that you're not looking at any respiratory depression that we need to counteract or deal with, and make sure that you have your reversal agent, which is Narcan, on hand. Demerol, again, the Demerol you'll see here is a administer, re-administer, and titrate, and also we can monitor the patient. This is the only one, again, morphine is the only one that is an infusion. This does not work in the infusion category. So you can look at this, your dosing is 25 to 100 milligrams, and that can be given either subcutaneously, which we really don't utilize sub-Q in the field anymore. We look more at intramuscular and slow IV pushes, and it can be given every 3 to 4 hours as necessary. But also, again, you want to make sure that you use it with caution if you have the patient that has a head injury with a chance for increase in intracranial pressure. IM is the preferred route of administration for this medication because it is pretty strong in comparison to the morphine. And then finally, we have included fentanyl into the lecture because, again, when the PowerPoints came out, fentanyl was not one of those approved medications, and it has become approved. This again, it is set to where even the intermediates or the advanced care technicians can provide this medication, but you all are able to continue monitoring the patient with this. Rapid administration can cause wooden chest syndrome, so we always want to be very cautious and do this as a slow IV push. And your typical dose is 1 to 2 mics per kilo. The state of West Virginia recognizes 1 mic per kilo, and it can be repeated at 50 mic increments every 30 minutes, but your total max is 3 mics per kilo, and that's whether it's an adult or a ped. Some of the side effects as a result of fentanyl can include hypotension, fatigue, and bradycardia, and also a prolonged QT interval. So you want to be very cautious in your cardiac patients. And your contraindications include someone who has significant respiratory depression, or if they have bronchial asthma, that's another big one, or if they've used monoamine oxidase inhibitors, or the MAOIs. Those within 2 weeks do not need to receive fentanyl. When we talk about the paralytics, these are your neuromuscular blocking agents that are responsible for paralyzing the skeletal muscles, and that helps us protect the airway by initiating and intubating that patient, an intubation for that patient. The only medication that we're allowed to utilize as C3 medics in this protocol is Norcuron. So Norcuron is given it can be administered primarily by a CCT paramedic, so that means that we can't do this. But we can re-administer as C3 medics. We can re-administer and titrate Norcuron as needed. Now again, remember, That means that we do not initiate that patient has to be already intubated, and the Norcuron has to have been given once already prior to us leaving with that patient from the hospital. So we can re-administer as necessary. This is a non-depolarizing neuromuscular blocking agent that will help us maintain airway management, and your dose is 0.1 milligrams per kilo IV. Onset is typically within 60 seconds, and they recover within 45 to 60 minutes, so it does have a higher amount of time associated with it. So hopefully your interfacility call will be close to done by the time you would have to re-administer. But of course, if we're bouncing these people down the road, there is a good chance that that Norcuron may wear off a little bit sooner, and also different people respond differently. But the side effects, of course, we want them to have the respiratory paralysis and the skeletal muscle paralysis so that we can actually protect their airway. When a medication is given to decrease systemic arterial pressure, then we're looking at an antihypertensive agent. And the one that we're specifically talking about today is cardizem. And cardizem can be monitored by the C3 medic. This is a calcium channel blocker that helps to slow the conductivity and decrease the myocardial contractility. So as a result of that, your cardizem will reduce your heart rate and the blood pressure. And it's indicated for patients who are experiencing atrial fib or flutter that have RVR, or rapid ventricular response, associated with it. So our biggest concern is the chance for hypotension, of course the chance of bradycardia. You may see a worsening of heart blocks, CHF, and peripheral edema. So we do not want to provide a patient with diltiazem or cardizem if they are already bradycardic, they have second or third degree heart blocks. And our maintenance infusion, what we're wanting to watch for is going to be 5 to 15 milligrams per hour, and that's IV. Again, this is an infusion that we're monitoring as a C3 medic. The rate...
Matt, come to dispatch, please, Matt.
Sorry, the rate is a continuous infusion that is set by the sending physician, and we are administering it as a monitor only. Monitor only. I'm going to take the moment to unplug the phone so that we don't have that interruption again. Okay, so with our volume expanders, these are our blood products. It can also be the colloids administered, and we're trying to maintain that intravascular volume. So we're trying to keep the fluid in the vascular system. And so we're looking at Hespan, Plasminate, and also our blood and blood products. So Hespan, again, we're looking at this as a re-administer, titrate, and monitor medication. And this is a synthetic starch. It's actually a colloid. It's really large, so it has a problem leaving the vascular bed. Once it's in there, it's kind of stuck in there. This is really good for patients who are experiencing hypovolemic shock as a result of burns, hemorrhage, and sepsis. So there's no major contraindications in life-threatening hypovolemic states. Some of the side effects can include vomiting, chills, itching, and a low-grade fever. But we do not want the dose to exceed more than 20 milliliters per kilo per hour IV, and it should be up to 1,500 milliliters in a 24-hour period. With the Plasminate, we are also looking at this as being a re-administered, titrate, and monitor medication. And again, it's another colloid. It's about maintaining volume, and it's great for the patients that are hypovolemic shock that are secondary to burns and also hypoproteinemia, so they have low volumes of protein. The blood and blood products, remember, this is a monitor only. We cannot re-administer or titrate. This is completely a monitor only. If we see an infusion reaction occur in the back of the truck, we must immediately discontinue that blood. So we're going to shut it down, and we're going to immediately start infusing normal saline as quickly as possible, and that is to protect the kidneys and make sure that we do not cause kidney damage. Also to make sure with the blood and the blood products that it has been going for 15 minutes prior to you leaving the sending facility. Now our vasopressors, we're going to look specifically at dobutamine, and again this is where we're trying to improve both the preload and or the afterload, and we're trying to improve the contractility of the heart muscle itself. So with dobutamine, this is a readminister and titration med as well as a monitoring infusion. So we can actually, make sure that this is continuing to work for the patient and titrate as needed. If hypertension, if we see symptomatic tachycardia develop as the result of the dobutamine, then we are told to discontinue it and contact MCP as soon as possible. Your dose for dobutamine is 2 to 20 mics per kilo per minute. We talked about the bronchodilators and the two medications that are looked at with bronchodilation for obstructive and inflammatory airway disease, and this includes the eluphant and theophylline. And I said we'd talk about them a little bit further in this section, so let's have a look. With the eluphant, this is considered, you can administer primarily, you can re-administer, and there's no need to monitor because this is a bronchodilator that's given via nebulizer. So it's a beta-2 bronchodilator. It is indicated for bronchial asthma and reversible bronchospasm that's associated with COPD. Contraindications include symptomatic tachycardia, cardiac arrhythmias, and any known hypersensitivity. The side effects, of course, it has the potential to induce tachycardia, create anxiety and palpitations in our patients. They may also experience chest pain, dizziness, tremors, and hypertension. Our dose is 0.2 to 0.3 milligrams in a 2.5 milliliter normal saline, and we're giving that in a nebulizer over 5 to 15 minutes, and it can be repeated every 4 hours. The biggest thing is that we want to monitor our patient for symptomatic tachycardia, any types of chest pain, and we want to see some improvement in their respiratory condition. Now in the case of theophylline is a monitor only. This is a bronchodilator that also works with vasodilation. It helps with those bronchospasms. It is contraindicated in any patient that's suffering from symptomatic tachycardia, hypotension, or if they have a known hypersensitivity. Some of the side effects, of course, include tachycardia, anxiety, palpitations, chest pain. You'll see it looks very much like what we saw with the eluphant. The dose is going to be dependent upon the lab work and what the patient assessment is. So again, we're looking at that to be based against what the physician has offered or what the physician is telling us. So when you have that patient that has been given theophylline, we want to monitor that patient for symptomatic tachycardia, any types of chest pain, and we hope to see a respiratory improvement. And it's not commonly used as an emergency medication. Now our anti-anginals, we're looking at something that's either going to affect the vascular tone or the pumping action of the heart, and we're trying to improve the blood delivery to the myocardial tissues in a result to reverse or reduce stress and workload. The medication we're talking about today is nitroglycerin. Again, nitroglycerin is considered a 3B and a 3C, so that means that we are able to re-administer, titrate, and monitor the patient with nitroglycerin. So we want to look closely at the concentration of the nitroglycerin before we start titrating and monitor the perfusion status and definitely the blood pressure. It's compatible IV tubing with heparin, and our dose can be somewhere between 5 to 50 mics per minute, and that's titrated in 5 mic per minute increments until we see the desired effects that we're looking for. Contraindications include hypotension, and our side effects, of course, can be hypotension, headache, and flushing of the skin. So this is indicated for patients that are suffering from acute coronary syndromes, or if they have congestive heart failure, or maybe they have hypertension. Our thrombolytics are agents that stimulate or convert the release of plasmin, and that helps to dissolve the clot and restore blood flow. It's commonly used in acute myocardial infarctions as well as ischemic stroke and in pulmonary embolies. Some examples of thrombolytics include the TPA, the Retivase, or the TNKs, and it's not considered a 3000 series medication, so you are not allowed to transport thrombolytics as a C3 medic. Your anticoagulants and antiplatelets, however, we do have some flexibility with those as C3 medics, and the medications we're looking at include heparin, low molecular weight heparin, and also such things as integralin, aggrastat, and ReaPro. Heparin is a monitor only for the C3 medic, compatible IV tubing with nitroglycerin. Common dose is 1,000 units per hour for most adults that have acute coronary syndrome, but the dose is going to depend on weight and medical diagnoses. So the biggest things we want to be aware of as side effects include spontaneous hemorrhage or thrombocytopenia. We definitely do not want heparin to be on board if we have active bleeding or a known bleeding disorder, severe hypertension, or a known hypersensitivity. Another medication that's a monitor only for anticoagulation is the low molecular weight heparin. Looks very similar to what we saw with the regular heparin. Our doses are administered sub-Q every 12 hours, and we just want to be very aware of any spontaneous hemorrhage that may occur. Then you have your antiplatelet agents. These include your integralin, your aggrastat, and ReaPro. And this is also a monitor only. The doses are administered by IV at various dosings, dependent upon what it is that is being dealt with. But we just want to make sure we monitor that patient for any chance of active bleeding. Our antiemetics has also added a medication to the list that wasn't in previous PowerPoint presentations, and that includes the phenagrin. Zofran and compazine were already included, and phenagrin has been added back into the list. So if you have a patient who's experiencing nausea and vomiting as a result of a disease process, or maybe the result of being transported in the back of an ambulance, then we can look at medications such as Zofran, compazine, and phenagrin. Of the three medications, Zofran is considered the one that the state of West Virginia wants you to go to first. It is an antiemetic. This potential for side effects include hypotension, tachycardia, constipation, and elevated liver enzymes. But the one thing you will see is that it doesn't have quite the impact in terms of the chance of extrapyramidal syndrome or EPS like the others do. So the administration of Zofran is considered a 3A and a 3B. You can administer it, you can be the primary initiation for it. You can also re-administer it and monitor for the effectiveness. Your dose is going to be 4 milligrams as a slow IV every over 2 to 5 minutes, and it's given every 4 to 6 hours as needed. Compazine again falls also in this category. It is a 3A and a 3B just as before. Your dosing is a little different though. It's 5 to 10 milligrams IV over 2 minutes, and again it can be given every 4 to 6 hours, but our max dose on it is 40 milligrams per day. But you will see here as one of the side effects is where we talk about that extrapyramidal syndrome, and that's where they have that involuntary movement. And then finally we have phenagrin, and phenagrin is considered a 4A and a 4B, so again we're looking at being able to be a primary administration for it and also a re-administer as necessary. It is not to be utilized in patients less than 2 years old. It's also like the compazine is like that, and the biggest thing that we have to worry about with phenagrin is the chance of sedation. Again, the dystonias, those muscle reactions that you see with extrapyramidal syndrome, it can cause bradycardia. And our dose is 12.5 to 25 milligrams, and that can be either given IV or intramuscular. And it can be repeated once in a 4 to 6 hours as needed. But any time you have to give an additional dose of phenergan, you want to run that through your MCP prior to administration. Our antibiotics, again, remember all antibiotics are considered a C3. You can take those. However, it's really important that you are only allowed to take one antibiotic during transport. You can't have more than one. So these are a monitor only. They can be infused. Only one can be taken by the paramedic, the C3 paramedic. And now we're going to take a look at the final little set of medications. You know, our Mannitol is being utilized in cases where you have someone with increases in intracranial pressure and the chance for potential herniation where you see the Cushing's reflex. So the administration of Mannitol is considered a 3B and a 3C. So we will be able to re-administer, titrate, and monitor as a C3 medic, but we need to make sure that we do this in consultation with MCP. Some of the things we need to be very aware of and look for include urinary output and hypotension, so we want to make sure we document those very closely. And the dosing is 1 to 2 grams per kilo as an IV push that's given over 30 to 60 minutes. Magnesium sulfate is a monitor-only medication for the C3 medic. This is an IV infusion that's going to be dependent upon the medical diagnosis. So again, we're going to look at what the physician is wanting to have as an outcome, and they're going to tell us what the dosing is or what they want that dosing to be. But it is a medication that is used to stop preterm labor, preeclampsia. It's also utilized in some cardiac conditions such as torsades and VTAC or ventricular tachycardia that may not be responding to any other type of antidysrhythmic. They may choose to go to magnesium sulfate. So our big concern here is watching for magnesium toxicity and being aware that we may have to use calcium gluconate as the reversal agent in this case. Sometimes we'll see steroids come up on the truck. We can re-administer and titrate and monitor these, but when you give steroids, you need to remember that it does have an impact on blood sugar. So you want to make sure that you monitor blood glucose levels anytime you introduce a steroid into the situation. But you want to consult with the sending physician prior to transport to make a decision if you're going to re-administer or titrate those medications during transport. We talked about the potassium chloride in the previous lecture. The biggest thing to remember is that we are monitoring this infusion, and we need to be very aware and very cautious of EKG changes and vital signs during transport, and we want to ensure that this is placed on an IV pump. Remember, potassium chloride can only be transported if it is on a pump, and the total dose, the concentration needs to be no more than 40 milliequivalents and 1,000 milliliters, and it cannot be given in less than 2 hours. It has to be 2 hours or greater in order for you to be able to take the potassium chloride. But potassium chloride is utilized a lot in cases where the patient is experiencing hypokalemia, so they have low potassium levels in the bloodstream that's requiring them to have some sort of supplement. The contraindications for potassium chloride include someone who's suffered from massive tissue trauma, maybe the case of a burn patient, or someone who's suffered from crush syndrome, or they have hyperkalemia. Romazicon, also known as Flumazenil, this is our reversal agent for our benzodiazepine overdoses. And the dose for Romazicon is 0.2 milligrams IV every 1 minute as needed, up to a total of 1 milligram. And this is a 3A, B, and C, so you can administer this as an initial dose, you can re-administer, and you can also monitor. So our biggest thing is to make sure that we are looking for the outcomes. We expect the desired outcomes. We want them to pull themselves out of the respiratory depression. Now the TPN, or the total parenteral nutrition, we are only monitoring this. We are not initiating this care for the patient. And it's going to depend on what their nutritional requirements are as to the dosing. So we want to just make sure we keep a very close eye on their blood glucose levels and ensure that the TPN is kept sterile during the administration. Our amiodarone is a 2A, a 2B, and a 3C. This is a monitor only for the C3 medic. We are looking for the effectiveness and for our desired outcome. Our dosing is 0.5 to 1 milligram per minute, and we want to make sure that we monitor the EKG for any changes such as bradycardia or heart blocks and hypotension. Remember, the patients that are intubated are probably going to be placed on proton pump inhibitor. Again, this is for patients to prevent peptic ulcer disease or to help treat peptic ulcer disease in GERD. This is considered a 3B and 3C, so you can monitor, re-administer, and titrate as necessary, but we want to make sure that we consult with the receiving or the sending physician about the specification of the medication order and the dosing. Antivenin, we talked about that. This is a monitor only, and it's for the patients that have suffered a bite from a snake, for example. Some dosing depends on the type of medication that's ordered and the animal source of the venom. So we're talking about things like crofab. Just be aware that our biggest concern with antivenin is the chance of an allergic reaction. Here again is where we talk about the calcium gluconate. It is a monitor only. The calcium chloride is. Remember, calcium gluconate can be used as a reversal agent as needed, and the dosing is going to depend on the lab work. So we're going to have to go with whatever the sending physician tells us. So IV calcium is considered a monitor only for the C3 medic. We're monitoring the EKG and vital signs. We want to make sure that we don't notice any bradycardia or EKG changes such as moving into ventricular fibrillation or toxicity. And then we have Procainamide. And Procainamide is also a monitor only. This is an infusion medication that's typically given to a patient who is in a ventricular dysrhythmia that did not respond like it should have to other antidysrhythmics. Procainamide is kind of considered down the line of importance there. So if they have been treated with lidocaine, for example, or amiodarone, and it's not working, then sometimes they'll look to Procainamide to try to correct that. Contraindications include the second and third degree heart blocks, cardiogenic shock, and congestive heart failure. And we want to be very aware that this medication can cause hypotension and bradycardia. Your dosing for Procainamide is 1 to 4 milligrams per minute, and remember, this is a maintenance infusion. Now, unfortunately, we can't get through pharmacology without talking about drug dosing and calculations. We're going to take a few minutes and go through these. I'm also going to include some informational videos on drug calculations if you need a refresher. But don't feel like you have to go through those. That's just there should you need the additional support on these drug calcs. The other thing to remember too when we go into the interfacility setting is we are going to be utilizing IV pumps much more frequently, obviously, than we do in the emergency setting. So there's a lot of different type of IV pumps out there. What I have done is I've included a video that gives you an overview of how the IV pump is set up. It's very generic, and it's the responsibility of you to make sure that whatever pumps we use in the squad or the sending hospitals you were educated on. So if you have one at the sending facility that you're going to be taking out, you need to make sure you are absolutely comfortable with that pump prior to leaving that sending facility. So this is going to keep, this section is going to talk specifically about the drug calculations associated with the IV pumps. So how do we calculate a medication infusion to an hourly rate that works on a pump? First, consider that most transport pumps have various settings that both allow for you to program in multiple configurations, including milliliters per hour, mics per hour, mics per kilo per minute, and so forth. And it calculates your rate for you once you enter the data. So remember that there are cases where you can still have human error, and that's really important. I have went on calls where I've checked to confirm that the IV pump was running at the doctor's requested dose and found that the person that set the IV pump up has actually set it at the wrong rate. You would think it doesn't happen that often. You would think, well, it's a computer, how can it mess up? It's not that the computer is messing up, it's that the handler of that pump puts the information in wrong, and as a result the pump does not provide the medication at the appropriate rate. So there is human error involved with this. So the order has to be adjusted to meet the capabilities of the pump. In most cases, this is milliliters per hour. The best thing I can tell you, we deal in the pre-hospital setting, we talk about setting up our infusions at drops per minute. If you use a 60 drop set, the drops per minute will always equal the milliliters per hour, and that's probably the easiest way to remember it. So if you know you have 30 drops per minute, you're going to be giving 30 milliliters per hour. So that's a really easy thing to kind of keep in the back of your mind. If you have drops per minute, it's going to equal the milliliters per hour as long as you're using that 60 drop set. But we're using an IV pump, so that makes it even better. The formula that I use is a doctor's order over dose on hand. Now, I'm sure you were taught a certain way in your medic class, or maybe you have your own method for doing this, and I absolutely do not want to mess you up. So if you have a set way of doing it, then don't pay attention to my way. Please don't. If you're uncomfortable and you want to try my method, you're more than welcome to. And again, I said that those videos are going to be included so you can use them if you need that refresher, but don't feel obligated to look at that. I always tell my students when they're going through and they're learning drug calculations for the first time is to find one way and stick with it. If they start incorporating different methods and different ideas, then all of a sudden those formulas get infused in their brain and gets tangled up, and it creates a huge issue. So again, if you're not used to using my way, please don't feel like it's mandatory to do it. Stick with what you know. But what I use is the doctor's order over dose on hand. So we're going to look at this formula. So here is our first case. We have Dr. Me, who has ordered a heparin drip to infuse at a rate of 1,000 units per hour as an IV. The heparin has come supplied to us in a premix of 25,000 units in 500 milliliters. So what do we want to, what is the rate to set the IV pump? So that's what we're looking at here. Right now we're talking about the doctor's order. The doctor has ordered you to infuse 1,000 units per hour, so we're going to place that on the top. And then the dose on hand is what we have in front of us. We see that we have 25,000 units in 500 milliliters, so we're going to place that on the bottom. Now the next slide, if you want to take and pause the video now to try to work out this calculation on your own using your own drug calculation formula, please feel free to do so, because I'm going to give you the answer on the next slide. So the first step whenever you're doing the drug calculation of doctor's order over dose on hand is we look at the bottom and we see that we have a very large number. We're going to divide that. So if you divided 500, the 25,000 by 500, you would come out with an answer of 50 units per milliliter. And I like this formula because it puts me down to small numbers. I don't like big numbers. That's when I tend to mess up. So Once you have that, you can translate that information down. So you have the 1,000 units per hour, that's our doctor's order, and the dose on hand has been calculated down to its smallest unit, and we're talking 50 units per milliliter. So now the second step is just to divide it again. So we're going to divide the bottom on the outside of the top, and we come out with 20 milliliters per hour. That is your answer. So here we're going to have another one. The doctor in this case is ordering a lidocaine drip to infuse at 4 milligrams per minute. You have in front of you a bag of lidocaine that's 2 grams in 500 milliliters, and the question is asking you how many milliliters per hour are you going to set your pump. So again, this is another one. The next slide I'm going to walk you through my method. Please feel free to stop the video and come up with the answer to this calculation on your own, and then we'll look at it further. So in this case, the doctor's order was 4 milligrams per minute, so we place that on the top. The dose on hand, we're going to go ahead and take that 2,000 milligrams in 500 milliliters, and we're going to take that bottom and we're going to make it small. So we're going to divide the 2,000 by the 500, and we come out with 4 milligrams per milliliter. That's what's on the bottom. So we're going to translate that information into it. So you have 4 milligrams per minute, your doctor's ordered, and then your dose on hand is 4 milligrams per ml. And then our second step, we've divided the 4 milligrams by the 4 milligrams. It comes out with 1 milliliter per minute, and we're going to multiply that by our drop set. And our drop set is a 60 drop set, so that means it's 60 drops per minute. And remember, the drops per minute equals milliliters per hour. So we're giving 60 drops per minute, we're going to get 60 milliliters per hour to that patient. So when you set up the pump, you're going to set the pump for 60 milliliters per hour. Now this is the final little question that they have in the PowerPoint presentation, and it says that you've picked up a patient at Way Out Hospital. The nurse has a dopamine drip running at 60 milliliters per hour. So we're wanting to make sure and confirm that things are matching the way they should be. You know that your patient is 176 pounds and the dopamine is supplied to you, the dose on hand is 800 milligrams in 500 milliliters. The order is for 10 mics per kilo per minute. So we want to make sure that that IV pump has been set up correctly. So take a minute, and we're going to pause the video now, and I want you to look and see if you can come up with the correct answer. So we're going to plug in the information we know. The doctor has ordered 10 mics per kilo per minute. We have a dose on hand of 800 milligrams in 500 milliliters. Remember, our first step is to take that bottom and get it to the smallest fraction. So we're talking about 1,600 mics per ml. And remember, we had that patient that was 176 pounds. We're going to divide that by 2.2, and we're going to multiply that by our 10 mics per kilo, and we're going to come up with 800 mics per minute. So our doctor's order is 800 mics per minute. Our dose on hand is 1,600 mics per ml. We're going to divide the 1,600 by the 800, and we come out with an answer of 0.5 milliliters per minute. We multiply that by that 60 drop set. That gets us 30 drops per minute, which we also knew means 30 milliliters per hour. And in that particular case, the pump says it's dropping at 60 milliliters an hour. So the sending facility set the pump up to the wrong amount, and we need to make the correction. So we need to make them aware that there's a calculation discrepancy and have them correct it before we leave with that patient. So again, that should be at 30 milliliters per hour. And that concludes the pharmacology section for the C3IFT Module 3. If you have any questions or if you need additional help with the drug calculations, my door is always open. Again, I'll have the videos posted You don't have to look at those, but those are there for your viewing needs. And then also remember that I'm going to provide you with the IV pump video so that you can look at it, and there will be some questions, some final drug calculation questions to finish this module out. So if you have any questions, give me a shout. Have a great week.